Ladies and gentlemen, please take your seats. We are 2 years late. I'm glad you laughed at that one because that's my best joke. So, welcome to INHSU 2020, or 2021, 2022. Hopefully, thankfully, we didn't order the food in 2020, so it's still fresh. So all is good. I'm John Dillon. I'm a hepatologist in Dundee, so I'm an outsider in Glasgow as well. Anybody from the east of the country is viewed with suspicion in the west. Better than coming from Edinburgh, but close. So all our international guests are extremely welcome, and you'll be treated like true Glaswegians. And hopefully you've experienced that warm welcome already. So thank you very much for coming. I'm sure you all are enjoying being here in person, and for those of you who are joining us virtually, you're very welcome as well, and we'll try and include you in all of the fun. Although passing whiskey down the internet is somewhat of a problem we haven't solved yet, but we're working on it. Okay. So welcome everyone to being here. So delegates, where are you all from? You can see we have a large number of delegates from across the world, so 794 from 57 countries and counting. So we'll hopefully have more people that have registered today and will be appearing shortly. So we are truly an international audience, and we've fulfilled the first part of our name, and hopefully we're going to deal with how we work as a network to improve health and hepatitis in people who use drugs. And so that's the really important message for today and for the rest of the conference. As you see from INHSUs over the years, people are starting to recognize the importance of this conference, this network of us working together to help improve the problems that we all face. And year on year, there have been more and more people. And I think for us in 2020, in our first sort of face-to-face international conference, to hit 794 people already is really good. And we should all feel very proud of the fact that we're here and able to network and work together. We've awarded scholarships for people to be here, so your registration fees and the sponsorship that comes through the conference is put back into investing in the network and bringing people together. So we have 32 community scholarships, 15 scholarships for practitioners, program and policy, and the new investigators, the young blood that will help answer the questions and problems that we have, are recognized and rewarded, and acknowledging the importance of hepatitis within prisons and how we move that forward is recognized in those scholarships as well, to allow those people who would otherwise struggle to get to this conference to be able to come and participate and contribute.
Are you able to unmute your microphone, please? And
I'm very grateful as the chair of this committee to the core organising committee, who are all listed up here, who have helped develop the programme. If you don't like the programme, it's your fault because you didn't tell us what you wanted.
Look, we've already started.
So please, when we give you feedback forms at the end of the conference or during the conference, feedback as to what the topics are that you think we should be covering, what we've covered well, what we could do again, what we need to add to. So your feedback is very important, but I'm very grateful to everyone on the committee for all of their help and support and major contributions. I just sort of sat in a chair and drank coffee at a Teams meeting. I didn't have to do very much at all. And we're also grateful to our local programme committee, all of whom are listed here, and I won't go through them all by name, but they have made major contributions to helping that programme develop, so it's just not my idea or Jason's idea or Rachel's idea. And we've also had an international flavour of people contributing their ideas and thoughts to make sure that we get this representative across the whole area. We are very grateful to our sponsors, Gilead and AbbVie, who have made contributions to allowing this to happen, and we would encourage you to talk to their representatives, etc., and interact with them and add to the, their value that they get out of meeting us and learning what it is they need to do next. And we have multiple exhibitors, of which who are generating devices and services that are of interest to our clients and to our people, and so please interact with them going forward. I don't wish to labour the point, but language is important. We have a very strong community presence here, which is incredibly important to the society and how we work together in the network, and it adds the expertise brought from that lived experience. So please try to avoid stigmatising language. We are all aware that stigma is a major issue across the whole of the spectrum of people involved with this field, and we need to make certain that we are being careful about our language that we use and are inclusive and allow people to use, to feel not to be stigmatized. And so particularly to use the term people who inject drugs rather than the shorthand abbreviation that you can use in text, but say it. People are people. And if you want more information about that, that's a reference that will give you appropriate information. We live in an age of social media. I'm told I'm too old to know anything and I'm allowed into Facebook, but nothing else. Some of you are much younger. Please, there is an online community that's going to be following us through the conference, but we need to extend our messages beyond that. And so for people who can't be here, so if you have social media accounts, please use those. The tag at INHSU and the hashtag INHSU 2002, and so for Facebook, Instagram, and Twitter, please tweet Insta and Facebook, book, don't know, whatever you want. Do what you feel comfortable doing, but don't feel inhibited about doing it. Talk about us. Talk about what you found interesting. Talk about what you found novel and clean. The people that you talk about will be really, really happy that you've noticed their work and give them that feedback. If you didn't get a chance to speak to them face to face, that's what you want to do. So that's my welcome, and myself and Rachel, who will be Halford, who's the Chief Executive of the Hepatitis C Trust, will be chairing this first session. Jason Grebley will be giving out some awards shortly, and we won't be talking to our Minister for Health, who hasn't managed to log in. So Mary Todd, who is the Public Health Minister and Sports Minister for Scotland, was supposed to be giving us an address, but it appears that there are some technical difficulties, so you'll be pleased to hear that you have much more time for questions and for answers afterwards. So, without more ado, I will hand over to Rachel to introduce our first speaker.
Yep, so good morning everybody, and actually I think it's, I'd love to have heard from Marie, but... Oh, there she's here! Oh. Fantastic!
So my technical nightmares continue. It is my pleasure to introduce Mary Todd, who is the Minister for Public Health in Scotland and responsibility for all things hepatitis C in Scotland.
Hopefully you can all hear me, yes?
Yes, we can.
Yeah, brilliant. Okay, apologies. It's wonderful to be able to join you, even if it is only virtually. I'm sorry I can't be there in person, but I'm up in the lovely Highlands in my constituency because it's recess week this week. So thank you very much to the organisers of this conference for inviting me here today. I am absolutely delighted to be part of such an inspiring event. As the Minister for Public Health, Women's Health and Sport, I'm continually astounded at the breadth of work that goes in across public health services. And I know there'll be loads of meaningful discussion over the next 2 days. Absolutely no doubt much of that will focus on how we can keep improving and keep delivering change. But I also hope that there will be an opportunity to reflect on, and for everyone to reflect on the progress that we've made and how proud you should all be of that. I'm going to do my best to lead by example in that, by highlighting just some of the achievements. I'm aware I don't have nearly as much time as I need to do that justice, so I'm just going to pick out a few areas that I think illustrate Scotland's success. So I'm sure most of you will know that in 2019, the Scottish Government committed to eliminate hepatitis C in Scotland by 2024. And that's a really challenging ask, and even more so when you reflect on what's happened in the few years since 2019. But we have tremendous reasons to be hopeful because we've already made major progress. We're extremely close to halving the prevalence, and indeed in some parts of Scotland, that reduction is as much as 60 or 70%, which is absolutely phenomenal. Now, that is in part because of the huge strides we have made when combating hepatitis C among people who inject drugs. And an example of that is last year we funded a project called the Cocoon Project, which is a project that provides person-centred, a person-centred approach, that holy grail of good practice, to people who inject drugs and are at risk of poor sexual health, bloodborne viruses and increased mortality. And it's collaborative examples like that that enable us to make major progress, and I'm absolutely incredibly grateful to everyone who's shown such passion and dedication to get us where we are. The second development I want to highlight is much more recent, but I think it also shows that how Scotland's leading the way. Now in 2021, 80% of the individuals diagnosed with chronic hepatitis C virus in Scotland had begun treatment with evidence to indicate that the vast majority had cleared the infection. Now, that number is remarkable, and it means that Scotland has already achieved a key World Health Organization target of treating 80% of those diagnosed with hepatitis C. It's a huge success, and one I hope that Scotland's public health workers are enormously proud of. I certainly am. And I hope we never lose sight of just how extraordinary it is that even over the last couple of years, clinicians, third sector organisations and support workers didn't just accept that outcomes would inevitably worsen. Instead, they pushed tirelessly for better, more effective services that put people at the centre and responded to their real needs. And that in itself is worth a couple of days of celebration. Of course, one of the challenges of working in public health is that there is always more to do. There is still work to be done. Despite the huge reduction in chronic HCV prevalence observed amongst people who inject drugs in Scotland, the incidence of primary infection still remains high. The link between treating bloodborne infection and tackling the drug crisis remains stronger than ever. And that's why the National Drug Mission remains a key focus for this government and why a collaborative approach is needed. And we've invested an additional £250 million over the course of this Parliament to reduce the deaths and improve the lives of those who are impacted by drugs. And that represents a 67% increase in funding from 2014 to 15 in real terms. Nonetheless, we know that the seriousness and the scale of that challenge in Scotland needs much more than simple funding, even though funding isn't simple in these current times. We need new, bold ideas, innovative approaches, and there are already some examples of that here. Scotland was the first country in the world to introduce a national naloxone programme. Earlier this year, we agreed plans with Police Scotland and the Scottish Ambulance Service to equip their emergency workers with naloxone and invested over £500,000 in a peer-to-peer naloxone supply project across Scotland. We've also set the groundwork for innovation through initiatives like safe drug consumption facilities. And the National Collaborative, led by Professor Alan Miller, is being established to ensure that the voices and the rights of those with lived and living experience and their families are at the centre, right at the heart of both policy and practice. These are the kind of innovations that I genuinely believe can change lives, and we need more of them. And that's why I'm so pleased to have been invited to speak to you all today, because conferences like this one, where we can take the time to learn from one another and can work out where the next innovation might be, these conferences are exactly where those innovations are born. So I wish you luck. I'm sure in years to come, some of the progress that we're reflecting on will have been inspired by this event. So thank you very much for having me.
Thank you very much. Right.
Yeah. Thank you very much to Marie, and she ended on there, hope that it would be inspired by this event. We had an incredible community day yesterday, and I'm going to hand it over to Jason Wallace, who's going to do the community opening. So Jason is from, and it's fitting after Marie's presentation there, joined SDF, the Scottish Drugs Forum, through systematic progression from being a peer researcher, volunteer, going through the user involvement activity to completing the SDF's award-winning addiction worker training project. He was to assist SDS in the National Naloxone Coordinator, and this includes the development of peer education networks, peer education training program, and the Naloxone Peer Educator Initiative. Jason is also SDO who managed the peer research and volunteering team. That's a huge introduction there, Jason. But also a co-chair to the community committee, and he's going to tell us a little bit about yesterday and the community statement. Over to you.
Thanks, Rachel. And just to echo what Rachel said about the community day yesterday, it was great. There was a great energy in the room, and thanks to yourself and Sione's co-chairs and everybody in the community. So we have a wee statement here on behalf of the community, and the aim of this statement is just to guide community activists and peer support workers to stimulate discussion and influence conference attendees. So the overarching principles of the statement is people who inject drugs or with a history of injecting drugs are the leading stakeholders in all aspects a Hep C prevention, treatment, policy, reform and service delivery, design, implementation and monitoring. We are a diverse community with diverse cultural backgrounds. Drug law reform and ending the criminalisation of people who use drugs is fundamental to the elimination of Hep C. Stigma and discrimination are a driver of the epidemic and create barriers to prevention and treatment. Any form of discrimination based on a person's drug use is unacceptable. People who inject drugs are rights bearers, and we have not given up our human rights, including the right to health, just because our behaviour is deemed criminal or immoral. Inequality in access to testing and treatment across the world is not justifiable and causing ongoing preventable deaths in our community. The health of people that use drugs is wider than blood-borne virus prevention and treatment. This party is for the research partners. Research must be community controlled. This is the only way to control the data and make sure it's appropriately interpreted and presented. Community control of research includes data ownership and early ongoing involvement. We know that this can be a complex task as most community organisations are under-resourced. This is for our government partners. The end of criminalisation of people who use drugs, scale up prevention globally, specifically needle and syringe programmes. NSP should include health services and be peer-led. Hep C transmission occurs via each piece of equipment and access must be scaled up and widened, including in prisons. Rapidly expand access to treatment and recognise that people inject a diverse range of substances beyond opiates. Polydrug use is the norm rather than the exception. Provide a safe supply of drugs for all, especially in areas where the illicit supply is contaminated or poisoned. Healthcare and treatment must be available regardless of citizenship or migration status. Recognise that this conference and many others are poorer for the lack of participation for the Global South. We were disappointed that many important community members were denied visas or travel to this event despite the best efforts of organisers. This is about embedded racism. Prohibition and criminalisation means that many communities cannot attend or obtain visas. And this is for health and medical practitioners, professionals. The The first principle of treatment access is empowering people to understand and demand appropriate health care. Ensure equal access to treatment regardless of substance use or injecting status. Deliver treatment with a holistic, multidisciplinary model of health. Ending the war on drugs would free up sufficient funding to fully fund Hep C treatment and prevention and offer a safe supply for everybody. So, on behalf of the Community Committee, there was a few important things raised yesterday. The community are more than happy to be involved in all aspects of research and service delivery and design and policy and strategy. But what the demand is that they're involved for the beginning. No a third of the way into projects or halfway through a project they get brought in. They weren't brought in at the beginning when the ideas are being discussed. It was also quite clear for yesterday that people want to see a clearly defined role in terms of volunteering and paid employment. People felt that a lot of the time they weren't necessarily paid a salary that was maybe equal to people doing a similar job simply because they were peer workers. They're also clear that they would like to have clear progression within organisations. So they may begin as a peer worker, but they want the same opportunities as everybody else, as me and you and everybody else here, to be able to progress through that career. And they were also quite clear that they would like to, whether volunteers or paid staff, have proper supervision and support in organisations, and be mindful if you're involved in the community in any bits of research, take into account the preparatory work that needs to be done prior to them coming and being involved. It isn't a familiar place for the community to be coming into big research projects or policy meetings or strategy meetings. So just be mindful that there's a wee bit of time needed just to make sure people are properly prepared. So when you're doing that project plan, have that in mind. But I'll just finish by thanking the sponsors in INHSU and the Secretariat support that we got at the community. Without all of that, the Community Day wouldn't have been possible yesterday. Thanks.
Thanks, Jason. And now moving from one Jason to the other Jason. There can only be two. I think we'll have to ban Jasons from now on. So my pleasure, Jason Grebley, who's the president of INHSU and is going to present some awards. Jason.
Great. Well, thank you so much. And Jason, thanks so much to you for all your efforts. And actually everybody from the community committee, Rachel, Sione, the entire group. It's something that we try to sort of strive to do at INHSU, is to really ensure that there's a strong community presence and involvement in everything that we do. And that, the work of that group, I think it's really strengthened that aspect of the network, and I just really appreciate it. So thanks, Jason. I heard yesterday was a great day. Look, it's been a long time. It's so amazing to see so many friendly faces, friends, colleagues. Yeah, it's been too long. When we were thinking about where to choose for a conference, we were trying to think of who was leading globally, both around hepatitis C and as we move into broader health of people who use drugs. And Scotland really was an obvious choice. The work that's been done here is truly internationally leading, both on the hepatitis C side and also on for drug user health. So I actually was fortunate. On Sunday, I got to drive throughout the countryside. We went up to Oban through Glencoe Valley, and you've just got such a beautiful country. And also the hospitality that we received across the entire trip was just breathtaking. We've actually been traveling for a couple of weeks throughout Europe, and it certainly has been a highlight. So I just thank you guys. I hope you guys have a great 3 days during the conference and experience the same hospitality that Glasgow and Scotland has to offer. So thank you very much. And on to the awards. So these awards are for the top ranked abstracts. They're objectively scored, so it makes it reasonably easy to select who they are. And I guess, you know, it's just these are for PhD students or other students, trainees, and these are the leaders of tomorrow. And so it's really a pleasure to to introduce these awards. So the first award for epidemiology and public health for top ranked abstract by a PhD student or other student. And if you want, actually, sorry, just to delay it further, if you'd like to just come up and just collect your award, and we'll, you know, do the shake hand thing, and then you can go back, and then we'll continue on. So the first award for epidemiology and public health research goes to Christian Malm from the Akershus University Hospital in Norway. Christian, are you here? Maybe not. They weren't notified that they were going to be awarded the award, so that you can tell them later. They'll be disappointed. Oh. Note to self for next year, attend the opening session if you're eligible for an award. The second person to win this award, I want to emphasize these are objectively scored, but is Joanne Carson from the Kirby Institute at UNSW Sydney for the top ranked abstract by a PhD student in clinical research. Joanne, are you here? I'm not supervising her, but she's in my group, or in our group. We'll let her know.
Clearly they were enjoying the hospitality too much last night.
Exactly. So the third award goes to, this is for the top ranked abstract by a PhD student for social science and policy research category. And this is being awarded to Tommy Brothers from the University College of London. 0 for 3. I'm sure their supervisors will have a chat with them about attending the opening session next year. No, seriously, it's great. I think, you know, credit to them, some amazing research, and you're going to hear lots and lots of great work over the next couple of days from both trainees and also from later stage researchers. So have a great week, and thanks for coming to Glasgow.
Hopefully our 3 students will be the last no-shows of our speakers for the rest of the conference. I'm beginning to feel got at. The minister almost didn't appear, now the students don't appear. Is Andrew Macaulay in the audience? Ah, relief. It's my pleasure to invite Andrew Macaulay, Dr. Andrew Macaulay, who works for Public Health Scotland and for Glasgow Caledonian University, who is an expert in epidemiology of hepatitis C and drug-related health and harms, to talk to us about evidence-based approaches for reducing drug-related deaths, what interventions work, and what does the future hold, which is something I'm sure we're all really interested and looking forward to Andrew giving us all the answers. There will be opportunities to have questions after the 2 speakers have spoken, so please think about your questions along the way.
Okay, good morning everyone. Thanks to the committee for asking me to deliver this opening speech this morning on a subject I'm very passionate about. And schoolboy error, thinking PhD students get out of their bed before 10 AM, but hopefully learn from that the next time. I've got no declarations of interest, and I'd also just like to welcome everybody to my home city of Glasgow. It's a real privilege and honour to see so many esteemed colleagues here. I think we thought we'd missed our opportunity when it was postponed in 2020, but I'm so glad it's went ahead now, and I would encourage you all to see as much of the city as you can while you're here. It's a great city to live and work in. I'd also like to just comment on how great it is to see so many people in person today. I've basically spent the last 2.5 years in my spare room with my pyjamas on, working on the COVID response. So it's great to actually get formally dressed again and see so many people. And I'm sure this picture will relate a lot to people who've been working in this way. Anyway, on to the serious stuff. So if you take one message home from the next 20 minutes, I want you to take this message home, and it's that every drug death is preventable. It's sometimes forgotten about when you see data that's quite difficult to look at, particularly very large trends in some countries. But we should always remember that every drug death is preventable and the toolkit is out there, and we'll try and cover some of that this morning. Now, what is a drug-related death? I was told to not assume that everybody's an expert, so I've tried to strip it back down to basics. And drug-related deaths are interpreted or defined in different ways across different countries and by different institutions. But today we'll be talking about the tip of the iceberg, which is deaths from accidental overdose. It's the most common definition of drug-related deaths we have. But that's not forgetting a lot of other deaths that are associated with drug use, including deaths related to violence, suicide, liver disease and cancers. And I just wanted to acknowledge that these deaths are just as important, but within the boundaries of the discussion this morning, we will be focusing on accidental overdose. So I was asked to look at trends. Now, drug-related deaths are on an increasing trend globally. They've more than doubled over the last 30 years. And before the pandemic, there had been around 130,000 deaths annually. Now, we know from other data that we've observed since the pandemic that that trend has continued to increase. And even in the US, the deaths there alone have exceeded 100,000 in the most recent year. And then if we look at those other deaths, they're on a much bigger scale. The ones to do with suicide and liver disease and cancers, they exceed more than 500,000. But the trends are the same. They've doubled over the last 30 years, and they're on an increasing trend. Now, drug-related deaths are not exclusive to one country or one region. They're a global issue that require a global response. But as you can see from the map, they tend to be more prevalent in higher income countries, such as in North America, such as in the UK and Scandinavia, and also in Australia. But I would ask people to always proceed with caution when you're comparing one country against another, because drug-related deaths are recorded and defined in different ways across countries. So sometimes country-by-country comparisons can be flawed. But caveats aside, two countries stand out more than most when you look at drug-related death rates, and that is the USA, and unfortunately my home country of Scotland. You can see from this chart here that when you compare the countries with probably more reliable data and in the high prevalence areas, the US and Scotland have rates that are at least 1.5 times higher. The next highest country, which is Canada, which also have exceedingly high rates, but more than 3.5 times higher even the rest of the UK and Australia. And if you plot these on charts, you can see how bad things are in these countries and how bad things have become, particularly over the last decade or so. You can see they've got very similar trends, and it's notable that really since about 2014, both countries have really experienced what we would call exponential growth in their drug-related death rates during that period. So things were really bad already, but they've got a lot worse over that period. And you can see there are some differences between the countries. This is a preprint. It was actually, Twitter's a great place for finding research that's really new. And there's people in there that are really good at visualising epidemiological trends, and this really shows the difference in the age profiles between Scotland and the USA. We have much higher concentrations of deaths around about age 40, whereas in the US it's much more spread across a broader age range. And again, this further highlights how more elevated the death rates are in these countries compared to places like Canada and the rest of the UK. But that aside, the countries share a lot of similarities in what is driving the drug-related death rates in those countries. Often it's not rocket science. It's quite easy to define what the drivers are, and the responses are there. Now, you'll be glad to know I'm not going to cover all of this morning, and there are speakers over the next couple of days, particularly Niamh Eastwood, will cover criminalisation, for example. But I did want to pick out some of these things just to compare the countries to see what is actually happening. Now, it goes without saying, if you've got a high prevalence of people at risk of overdose, you're more than likely to get high rates of drug-related deaths, and the data confirms this. If you look at I don't think I've got a pointer, but if you look at the graph on the left-hand side, you can see that the countries that have got high prevalence of people at risk of overdose are clustered to the top right. They're the outliers, whereas the vast majority of countries are clustered to the bottom left. And you can see the outliers are Scotland and the US, perhaps unsurprisingly. So when we've looked at that, the more people at risk, the more deaths you're likely to get. So that emphasises the importance of primary prevention in relation to this area. And interestingly, if you bring back that graph I showed you a couple of slides ago, the other countries that are at the top of that graph are also clustered to the top right. So this isn't just a US and Scotland phenomenon. Also, if you have a toxic drug supply, you're likely to get high mortality. Jason mentioned the toxic drug supply there. And both Scotland and the US have very toxic drug supplies. North America is obviously characterised by synthetic opioids, which is very clear on the graph. In Scotland, it's slightly different. We don't have a synthetic opioid issue here in Scotland. Our drug-related death rates are mostly feature opioids, but also what we would call street benzodiazepines, so non-prescribed illicit benzodiazepines. And you can see how much of a feature they become in our drug-related death rates over the last 5 or 6 years. And the toxic drug supply is really the fundamental principle behind safe supply interventions, which are now being talked about as a key response in the overdose crisis in these countries. Now, a relatively new feature in both countries, and actually across many other countries, is the rise of stimulant use, particularly stimulant use in populations that we would more associate with opioids, for example. So in Scotland, this has very much been a real shift from people who would traditionally use drugs like heroin and methadone to now also injecting powder cocaine, either alongside or in substitution of those drugs. And you can see also in the US, we've seen this rise in stimulants as well, a phenomenon that Dan Ciccarone has called the fourth wave of the US overdose epidemic. And then drug deaths fuel health inequalities, and I think this often doesn't get talked about. Health inequalities often get talked about in relation to class, in relation to gender, in relation to age, but drug-related deaths fuel health inequalities as well. And this is a more recent analysis when we think about life expectancy. Life expectancy is a key marker of a country's health inequality status. And you can see in 2020, drug-related deaths took a full year off of life expectancy for men in both the US and Scotland. So these are pretty shocking statistics that you wouldn't normally expect in kind of Western high-income societies. And the populations experiencing that loss of life really are our most deprived communities. The graph on the right shows the difference in drug-related deaths, whether you live in the most deprived part of the country or the least deprived part of the country. And in Scotland in 2021, you were 15 times more likely to experience a drug-related death if you lived in the most deprived compared to the least deprived parts of the country. So how do we respond? As I've said, this isn't a new infectious disease that's kind of been discovered that we don't know how to treat or we don't know how to vaccinate against. Drug-related deaths have been with us for a long time, and there's an extensive evidence base there in how we tackle them. I was asked to look at therapeutic and non-therapeutic interventions. I don't really like the term non-therapeutic, so I've called that community interventions. What I won't address today is the social determinants of health. I would like to have done that, but we don't have time. But there'll be other people who will address that over the next couple of days, particularly Dame Carol Black in her speech tomorrow. But I just wanted to acknowledge that any strategies to address an overdose crisis in a country must address poverty and inequality, which drives these epidemics in the first place. So if we start on the therapeutic interventions, opioid agonist treatment, as most people will be familiar with, is generally the treatment of drug use disorders through prescribing drugs like methadone or buprenorphine. And there's an extensive evidence base for the effectiveness of opioid agonist treatment in the prevention of mortality. This forest plot here is from the most recent systematic review and meta-analysis, of which there are many out there, further confirming the protective effect of these therapies. It showed that all-cause mortality and mortality from deaths like suicide was reduced by up to 50% for those on treatment, but it was drug-related deaths where the biggest benefit was gained, with a protective effect of up to 60% for those on treatment. So it's still remarkable that this type of treatment receives stigma in some quarters, including in this country, despite the wealth of evidence behind it. So how do we increase access to OAT? I'm not going to go through all these one by one, but I would point people to the medication-assisted treatment standards in Scotland that were published last year, which are a really good kind of compendium of all you need to know about OAT and effective ways to get people engaged. And a lot of them are logical, kind of practical steps, including providing people with quick access and giving people choice around the treatments and their dosage, but also not judging people if they're continuing to use substances and providing harm reduction interventions at point of engagement. I also want to emphasise that take-home naloxone saves lives as well. We've also had some people querying this in certain quarters over the course of this year, which baffles me, I have to say. But naloxone's a bit behind OAT in the evidence base, but has now been with us for about 25 years as an intervention, and there's good evidence to show that it reduces mortality amongst people who've taken part in these programmes, and it's rarely associated with an adverse event. What naloxone, I think, has struggled to demonstrate so far is its impact at a population level, just because the studies are slightly more challenging to do. But the people who are furthest ahead in this and make me slightly jealous that it wasn't us that did it, because we had the first programme, are our colleagues from British Columbia. They've really been able to demonstrate the impact of rapid scale-up of naloxone at a population level and what impact that can have on death aversion. And you can see they studied the impact of naloxone's rapid scale-up between 2016-17 at a time where overdoses were rapidly rising in that territory as well, and were able to demonstrate that naloxone was associated with aversion of 1,600 deaths, which was more than overdose prevention sites and OAT combined in that state at that time. And I think we need more of these kind of studies to build up the evidence base on naloxone's population-based effect, because we've very good evidence on its individual level effects at the moment. And how do we increase access to naloxone? I think Kirsten Hosper is in the audience somewhere. She helped me put this together. But again, some really practical steps here about making naloxone much more accessible, removing any affordability issues to do it, making it available at high-risk points of overdose, particularly when people are liberated from prison or discharged from hospital, and also widening the network of providers and carriers. And the Minister mentioned police, for example, which has been one of the breakthroughs we've had in this country. The police are now on board and carrying naloxone day to day, and have been using it to save lives over the last 12 to 18 months. This one I added in because INHSU is mainly a Hep C conference, or has been until recently, and there is this emerging evidence now about potentially the role of direct-acting antiviral therapy. We know this is effective in reducing morbidity and mortality related to hepatitis C, but there is emerging evidence that it might be effective in reducing drug-related deaths as well. And this is the largest study we've had to date. Again, it's from British Columbia, suggesting that it's associated with up to a 75% reduction in drug-related mortality for people who were on DEAs compared to people who were not. And I think this type of study is an interesting one, and one we might try to replicate in other territories and other countries to see if this effect holds. But it's certainly a new emerging evidence that we're very interested in. And how do we increase access to DAs? There'll be lots on this over the next 3 days, so I won't labour on it, but we really need to simplify the models of care, moving away from solely hospital-based treatment to more community-based treatment, and I think there'll be lots of demonstrations of that over the next few days. Briefly talk about non-therapeutic or community interventions. Drug consumption rooms have received a lot of attention, particularly in this country over the last few years, and they're obviously visible in many countries throughout the world. Despite the UK being what we would think is a harm reduction pioneer or leader, we're very much behind the curve on drug consumption rooms. And they're most effective in areas with a high prevalence of people who inject drugs. So they're most effective in that local context. They're not a national solution to drug-related problems unless you have them in every community. They're very much more targeted towards areas where there are local issues. And interestingly, in the US and Scotland, two of the countries with the highest rates, there are no official drug consumption rooms operating at the moment. And in terms of the evidence base and reduction of mortality, there are some studies, including this one from Insight in Vancouver, which showed that the drug consumption room there was associated with up to a reduction in about a third of overdose-related mortality within the vicinity or the immediate vicinity of that site. There was no change in mortality in the rest of the city, very much emphasising the local impact of these services. And there's been similar studies done, particularly in the sites, including in the one in Sydney. Drug check-in services are similar to drug consumption rooms in that they are much more local targeted services, and it's sometimes difficult to untangle the impact of those services in the presence of such larger scale therapeutic interventions such as OAT. But they are again effective at giving people harm reduction advice on what's in their drugs, with the potential of informing people to make an informed choice about how to use that drug safely. And despite the difficulties in doing these type of studies, linking them with mortality, people have now started to make attempts at that. There has been one study from Insight looking at people's intention to change their dosage, and that was associated with a reduction in overdose. And then this really interesting study I discovered in researching for today, the protocol for a study in Toronto where there's been a rapid scale-up in drug checking services, and where they will look at that rapid scale-up and how it impacts on overdose rates in that city. So I was also asked to not talk about the negatives all the time and show the really bad statistics about how countries are struggling, and try and understand if any countries have turned around their overdose crisis, and are there any good news stories out there. And of course there are good news stories, Switzerland being one of the most obvious examples. So people will probably be familiar with the Swiss story in terms of open drug scenes in the 1980s, particularly places like Needle Park in Zurich, which prompted the Swiss government to take a radical approach to drug policy in their country, which was defined as the 4-pillar model, the 4 pillars being prevention, treatment, harm reduction, and what they called repression or law enforcement. And the original aims were to try and stabilise the situation in the country and reduce the overall prevalence of people on hard drugs or people drug dependent, and also to reduce the problems associated with drugs in that country. And there were some very particular characteristics about that Swiss model. In particular, the treatment model was very much rooted in OAT, but it was very much pioneering the use of heroin-assisted treatment. And heroin-assisted treatment is available widespread in Switzerland, and a lot of our learning about heroin-assisted treatment comes from Switzerland. And again, this is not something you see en masse in countries that are struggling with their overdose crises at the moment. In terms of harm reduction, they were also one of the pioneers of drug consumption rooms, which are also widely available in that country. And did it work? Well, I think the proof of the pudding is in the graph here on the left-hand side. This is the number of drug-related deaths in Switzerland since the onset of that policy came in. And you can see that drug-related deaths reduced by about 50% between 1991 and 2010, and have managed to maintain themselves at that level, despite a period where many other countries have seen their drug-related deaths begin to increase. And it's also had additional benefits on HIV and the overall prevalence. I'll briefly just mention Portugal, because it would be remiss of me not to mention Portugal, which is always held up as an exemplar. It's a similar model in some ways to Switzerland in terms of its multi-pronged approach. Decriminalisation gets lots of attention, but there was also a huge amount of investment in treatment and care and harm reduction. And for a long time, the Portuguese drug-related death rate has been below the EU average. But it's just interesting to observe that things seem to be changing in Portugal, and it'd be interesting maybe to discuss that over the next few days as to why that might be. Some people have attributed it to austerity, other people have attributed it just to a change in recording of drug-related deaths between the first decade and the next decade. But regardless, the trend seems to be going back upwards in recent years, and I think it's something we should be concerned about. I'm getting hurried for time, so I'll just quickly skim through the gaps in the evidence base. This is not an exhaustive list. This is just things I think are important, and I think things we should be studying more in the coming years. Polydrug use has been highlighted as a key issue. People don't die from consumption of a single drug alone. It's usually consumption of multiple drugs at one time. And these polydrug combinations have changed markedly over the last 10 years. And they're not just affecting mortality rates, but they're affecting our response as well. Our treatment response has largely been a treatment response based on opioid use, but now people are using opioids, stimulants, benzodiazepines, all simultaneously, and this is affecting their engagement with treatment. And I think we need to understand that better and evolve and modernise our treatment response in the same way. We've talked about safer supply. The impact of combined interventions of drug-related death risk has been demonstrated in terms of what you can do in British Columbia, and I think we've got good evidence for that for bloodborne virus, but we have lacking evidence in the drug-related death field, and we need more of that. And then everybody wants to forget about COVID-19, but a lot of good things happened in COVID-19 in terms of drug policy and drug practice, and I think we need to cherry-pick the things that did work really well, evaluate them and make them standard practice, but we also need to get rid of all the bad things that happened during that period as well and not normalise them in any way. So just to summarise, I think I was asked to do 3 to 5 take-home messages. I won't get through them, they're on the screen. I'm out of time. Thank you.
Thank you, Andrew. And just to say that there is an opportunity for you all for questions after our next speaker, which is brilliantly leads on to how can we overcome legal barriers to reduce criminalisation and improve the health of people who use drugs. I want to invite Niamh Eastwood to speak. Niamh is the Executive Director of Release, the UK Centre of Expertise on Drugs and Drugs Law. Niamh has also co-authored a number of Release's policy papers, including A Quiet Revolution, Drug Decriminalisation Across the Globe, and The Colour of Injustice, Race, Drugs and Law Enforcement in England and Wales. Niamh is also responsible for drafting many of Release's briefings for parliamentarians and policymakers, and she presents at international national conferences and regularly invited to comment in, it's long, it's really long.
Thank you, Rachel. Thank you so much. It's an honour to speak here today, and I wish I had sent a shorter bio. I also want to say Release is an organisation that provides legal services and expert drug services to people who use drugs and those who are affected by the drug laws. So every day we are dealing with the legal problems faced by the community that are most impacted by drug prohibition. I was asked to talk about overcoming the legal barriers to reduce criminalisation and improve the health of people who use drugs. And on reflecting that title, I decided that the only way that we can do that is to dismantle drug prohibition. The war on drugs has arguably been the most abject failed policy that the modern world has seen. It was enacted 50 to 60 years ago. The aim of the policy was to reduce and repress drug use. On its own outcomes and merits, it has failed miserably. Drug use has increased every year, year on year. The UNODC last year reported that 284 million people used a controlled substance. 13% of those, 38 million, are considered to be drug dependent. So it's failed to reduce drug use. It's failed to eliminate drug use. And it does so in the most brutalized way through the criminal law and through punishment and punitive measures. And these punitive measures have resulted in the over 500,000 deaths that Andrew referred to in his presentation. We also see that it has contributed directly to the increase in bloodborne viruses and other health harms that are faced by people who inject drugs. To me, it is not surprising that even in countries where we have effective harm reduction, we still have reasonably high rates of HIV and hepatitis C transmission, which can be avoided through the availability of sterile equipment. But why are people not accessing that equipment? Well, when you are first and foremost defined as a criminal, why would you put yourself forward in those circumstances? Why would you take that risk when it can have so much negative impact on other aspects of your life? And then we have those countries, such as Russia, that refuses to allow the legal supply and possession of this equipment, where illnesses like HIV, viruses like HIV and hepatitis C are devastating those communities. And beyond the direct impact of drug policy on people who use drugs and people who supply drugs, there's another group of people who are affected. People who are subject to drug policing. Now, often these are intersectional groups. Often they are people who use drugs who feel the brunt of law enforcement. But often they are also people who are just subject to drug law enforcement as a form of racial and social control. So research that we've done at my organisation looked, along with LSE and Stopwatch, looked at the patterns of drug law enforcement in the UK and in England and Wales particularly. And what we found was that black people were 9 times more likely to be stopped and searched for drugs, despite using drugs at a lower rate than the white population. It was twice as likely for Asian people. And when caught in possession of drugs, black people were treated to much harsher sanctions. They were more likely to be arrested. they were more likely to be prosecuted and more likely to be sentenced, whereas white people were more likely to get out-of-court disposals, which doesn't result in a criminal record. And I would argue a criminal record has a deleterious impact on health, that it undermines your educational opportunities, it undermines your employment opportunities. So we know that the drug laws are applied in an inequitable way. We also know that drug use is ubiquitous across society. It is every social class. You just need to look at not the last Tory leadership campaign, I think we're on the second or third of those, but the one that led to Boris Johnson being elected, where every one of them admitted to their drug use, bar one, and who had never had a criminal record. But when we look at the patterns of drug law enforcement, we can see that drug law enforcement is not applied in the same way. And again, the research that we did looked at inner city areas of London and the experience that they were having with drugs policing, whereby people were being stopped and searched at incredibly high rates. And I worked directly with a lot of these young people, and they talked to me about that experience. So these are young black kids from inner city deprived areas who talk about the fact that when they leave their house, they're scared. They don't know if they're going to get to school without being stopped and searched. That makes them feel fear of police officers, fear of the state. It makes them feel surveilled. It makes them feel that they're a criminal. Again, I would argue that those experiences are detrimental to health outcomes. And we see this experience in no clearer way than we look at deaths at the hands of police. So the deaths of George Floyd, of Breonna Taylor, in the UK of Rashan Charles, where they are labelled as drug user or drug supplier, and that somehow legitimizes their deaths, their murders. And I think Natalie Papillon puts this really well when she says their deaths are visceral reminders of our long sordid history of using drug use, real or imagined, to control, criminalize and brutalize minority communities. And this plays out across the globe. These human rights abuses repeated time and time again. Duterte's war on drugs, where we estimate that 27,000 people have been subject to extrajudicial killings, and where the population of the Philippines are actually in support of this policy, where they believe that it is legitimate for these deaths, these killings, these murders to happen. And that is because people are seen first and foremost as criminals. And when we have the criminal law as the predominant definition of how we handle drugs, then we have the situation where the state is legitimately taking or illegitimately taking the lives of some of the most vulnerable. And beyond the oppression that we've seen by states, the drug laws prevent people from getting the help and support that they need. A recent survey from or a recent research paper from the Higher Education Policy Institute in the UK found that 16% of students who found themselves in scary situations with substances did not seek help for fear of punishment. That is either punishment from their universities or punishment by the police. We must move away from a punitive approach to drugs if we want to improve health outcomes. The criminal law also actively blocks life-saving interventions such as the overdose prevention services. But again, it also legitimizes decisions by state actors and local actors to take away funding or not support certain services. We just have to see that most recently in Middlesbrough, where we've seen the funding for the heroin-assisted treatment program being cut. We're in the middle of a public health crisis. Even in England and Wales, every year for the last 10 years, we have recorded record levels of drug-related deaths. In any other area of health, this would be an outrage. Why is it not an outrage amongst the population that we work for and with? So, as Rachel said, we've written quite extensively about decriminalisation. And when we first wrote this paper back in 2012, I think there was about 21 countries that had adopted a non-criminal justice response to drugs. So either it was a no punishment model or civil sanctions for possession of drugs. At that time, I think it was really held out that Portugal was the only country that had done it, and that was simply not the case. But also, it didn't feel that there was a huge push towards decriminalisation, and I think amongst our organisation, Input, the our International Drug Policy Consortium, we've really seen a growing advocacy push for ending the criminalisation of people who use drugs. And we're 10 years on for the first report, and now we have the UN taking the position that decriminalisation is the model that every country in the world should take in relation to drug use. So at the end of 2018, the Chief Executive Board of the UN, which represents all of the 33 agencies, including UNODC, supported decriminalisation as the preferred approach to drugs. So just to say, decriminalisation is not unusual. We estimate now there's about 30 countries across the world that have ended criminal sanction for drug possession offences, and that is mainly all drugs, not just cannabis. We have a further 50 states in the US and Australia that have decriminalised cannabis, and that's helpful from an evidence point of view. Portugal has already been mentioned by Andrew, and as you all know, the reason I mention it is it's probably the best researched of the models. But as I said, it's not the only model. And it's certainly not the first country. Uruguay, for example, has never criminalised possession of drugs, ever. Uruguay seems like a grand country to me. Spain decriminalised possession of drugs, not only possession of drugs, but social supply of drugs, back in the late 1980s through a constitutional court decision. I've been to Spain many times. Beautiful country. Sky didn't fall in. But Portugal gives us some evidence. And in the first 10 years of the policy, there was a decrease in use amongst vulnerable groups, a in young people transitioning to Class A drugs, a 40% decrease in injecting drug use, more people in treatment, a significant decline in HIV transmission and hepatitis C transmission. Andrew's pointed to the fact that the drug-related deaths have increased in the most recent reports from EMCDDA. But I think it's really important to note that it is still much lower than the rates that we have in the UK and in Scotland. And then there's the cost-benefit saving. So even for those who don't care about the lives of people who use drugs, which is the reason I do the work that I do, but for those who care for the economic argument, it's there. The policy saved 18% in social cost of drugs in the first 10 years. And that was linked to a reduction in criminal justice savings, or criminal justice costs, a reduction in health savings, and that was obviously when you were dealing with acute issues in the community through drug treatment services. That then reduces the burden on the national health system. And as I said, Portugal not the only country in Europe to have done this. A number of countries have. Czechia, Czech Republic, have also a remarkably low rate of drug-related deaths, and they have had some form of decriminalisation since the late 90s. And their current drug-related deaths are 6 per million of the population. And across Europe, those countries that have some form of decriminalisation, some do it well, some do not, but they all have lower rates of drug-related deaths. And I am not for a second in a room of academics and researchers saying that decriminalisation results in this, but I would argue that it creates an environment where people feel safe. They feel more supported to go and access either the drug treatment services that they need or the emergency help that they need if they're in trouble, like those students I pointed to earlier. And again, we see growing moves towards decriminalisation across the world. So Vancouver have brought in, or British Columbia, have decriminalised possession of drugs from June 2022 for a 3-year period. The federal government there have given a moratorium on prosecutions for drug possession offences to address the toxic supply death crisis there. And then in Oregon, another US state that's been hit pretty hard by the overdose crisis. In 2020, there was a ballot initiative, and Oregon really interests me. So in 2020, they had a ballot initiative. So that's a public vote where the public get to say yes to a new policy idea. And so I think a lot of the time we hear from politicians that you can't do this. It's not possible. The public aren't with us. I don't think the evidence is there for that. I think the public are far more ahead on this issue than politicians are. And with decriminalisation in Oregon, what they did was they put forward the model that will work in practice. And how the model works, and it's not perfect, but it's more closely aligned to where I'd like to see it. And when police catch someone in possession of drugs, they are given a fine, but the fine can be waived if they contact a drugs helpline. That helpline will give them some harm reduction advice. It will provide them some information about local treatment services. And so it's quite a low threshold approach to dealing with drug possession offences. Doesn't go as far as I'd like it to, but it's quite low threshold. What was really interesting as well, though, as part of that public vote, Oregon had legalised cannabis back in 2016. And at that time, it was expected that the cannabis market would yield about $40 million in taxes. It yielded $300 million in taxes every year. And so what they did, what these brilliant advocates did, is they said, well, all that extra money that's coming from the taxes for cannabis, can we put that towards health, housing, towards drug treatment, create a social safety net through the taxation of cannabis. Now, my view is it's up to the government to take that role. But my God, if taxation from cannabis is going to help us provide those basics that we need, that addresses poverty, that addresses housing issues, then we should be supporting that. So we should be thinking about, because we will be in a situation soon where cannabis legalization comes to every country in the world. This is a big industry. We need to think about how we do it from a public health point of view and how we can use it to contribute to broader public health outcomes and hold those companies to account. But as I said, the decriminalisation matters, and whilst Oregon is positive, I'd like to see it go further. We should be advocating for no punishment models. And here I'd like to call out the work of our brilliant colleagues at the International Network of People Who Use Drugs, who have highlighted the situation in decriminalisation in Portugal, who have said, yes, there have been advances and the model has had positives, but police are still harassing people who use drugs. There is still surveillance of people who use drugs. That still causes the harms that I mentioned yesterday. And it does nothing to address the damage that is done to those communities who are subject to over-policing for drugs. And it's the driver of over-policing. So, for example, in the UK, 70% of all stop and searches are for drugs. This is not about property crime. It is not about violent crime. This is about policing low-level possession offences. And I mentioned the experience of the young people that I work with who talk about trying to navigate life as they are constantly subject to police interactions. And last week, I was at a lecture at Birkbeck University. There's a brilliant racial justice fellowship going on there that's run by a fabulous academic called Kojo Koram. And Kojo and a colleague of mine, Imani Robinson, have brought together a group of young people from Tottenham, which is an inner city area of London. And we were talking about cannabis legalization. For them, it's amazing that this is happening. And they said, but you know what the problem is in the UK is that everybody thinks that the issues in our communities is to do with cannabis. It's to do with the fact that we smoke cannabis. And what they don't understand is that when we leave the house, we are confronted by the violence of poverty, by the violence of the state towards us, and by the violence that we witness in our communities. And so our drug use is a rational response to that. And that really echoed to me about the idea of rational drug use, how even when we use in a dependent way, it is a rational response to the traumas that we either experience at an individual level or a societal level. And so when we talk about decriminalisation, we must push for that no punishment model. We just again have to look at cases such as Child Q in the UK, where stop and search in this country, you can extend it to strip search without arrest, where a 15-year-old girl, again in a school in Hackney, was subject to strip search because she was suspected of having cannabis on her possession. The violence of that, the trauma of that. I mean, this conference is about health, and I want us to think about health in the broadest sense. But decriminalisation, even with no punishment, again, is not enough on its own. We must be pushing for safe supply. In no world is it better for drugs to be coming from an unregulated toxic market. In no world. And again, we must be looking at models of reform that are based on public health principles that seek to repair some of the damages, all of the damages, if we can, of the drugs trade, of drug prohibition. So the damages that have been done to those communities that have been over-policed and over-criminalised, people who use drugs, people who are from deprived communities, people of colour. And so, like Andrew, they asked me to come up with 4 or 5 asks. I have 2. And Jason really pushed this home in the community statement. 50% of people who are dying in the UK, and I think this is true for Scotland as well as for England and Wales, have not been in contact with treatment services for 5 years. Why is that? One, is that being a criminal first and foremost? Secondly, what are services not doing to get to those people? And I would say that the answer to that comes from people who use drugs. Service users, it comes from people who are active users, and that they need to be involved in every aspect of the work, in the design, the delivery, and the direction. We have to end paternalistic and controlling treatment environments. We have to stop the surveillance. Secondly, decriminalisation, decriminalisation, decriminalisation. Talk about it in every aspect of your work. Remind lawmakers, remind policymakers why criminalisation does not allow you to do your jobs. And in every opportunity that you have, argue for decriminalisation. Ask your regulatory bodies to come out in support of this policy position. We will all be better for it. Thank you.
Neve, don't run away. Come across this way.
Questions. Yeah.
So I've asked Neve and Andrew to join us on stage. It's now your opportunity for asking questions. There are multiple ways you can ask questions. You can, on your app, find the question bit, send it to us, and it will appear here by magic. So if you want to do it anonymously. For those of you who are watching online, you can do it through the app, or you can apparently use the right-hand side of the screen that you're in, and they will appear. And if you're feeling brave, we have microphones there, 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 and there. I feel like an air hostess. Right. The session is now open for questions. Do we have any questions? Microphone 3. Can't quite see who it is. Please tell us who you are and where you're from.
Anyway, good morning, everyone. Niklas Luhmann from WHO. I had one comment to the overdose presentation and one question. The comment was just in terms of the epidemiology of drug-related death. I think not only is there differences in reporting, but if we think about some low and middle income countries, I simply think we don't know how much drug-related deaths there are compared to Scotland, Canada, or the States. If you think of Afghanistan or Myanmar or many other places, I just wanted to acknowledge that. And a question in terms of reducing drug-related deaths around treating comorbid mental health conditions, which you didn't mention. Was there a reason why you didn't mention that, or do you think it would not be impactful? Yeah, that was the question to you. Thanks.
Andrew.
Sorry, I think the question was, should we be treating comorbid mental health as part of drug treatment and the impact that can have on drug-related deaths? Is that right? Yeah.
That's right.
So on your first point, yeah, I completely acknowledge some countries probably don't record drug-related deaths at all, and that's a big issue for us. On the comorbid mental health, I think we flagged that as one of the key components of the medication-assisted treatment standards. So one of the main ways to engage people is to make sure that mental health is a core component of that treatment, not just once people are engaged, but immediately when they're engaged. And certainly the evidence shows us that people engaged on opioid agonist treatment the reduction in deaths, such as suicide, for example, can be, you can get gains of up to a 50% reduction in that. So the importance of treating comorbid mental health as part of a drug treatment programme and not as a separate issue, often called the dual diagnosis ping-pong effect, where you're referred to mental health services for your mental health and back to drug treatment for your drug dependence. I think the emphasis these days is to treat them both at the same time while people are engaged at that key moment. So absolutely agree with that.
Thanks, and just wanted to say I should have started to say that it was a lovely opening and very good presentation. Thanks.
Thanks. Microphone 2.
Good morning, people. My name is Ashish Brahma. I'm a forensic medical doctor from the Netherlands. And what I see in my practice is that many people enter into poverty, have multiple problems, and that we have an issue of access to health because either you are mentally unstable, i.e. have a psychiatric problem, or you have inborn errors that you're not so smart, or you have an addiction, and we seem to have special services for every single isolated issue. So my question is, if I see that there's a divide in the Netherlands, it's difficult to get access to health, how do we people that are working in care make sure that politicians and civilians understand that it is never one issue, it's always a multi-dimensional issue? That's my simple question.
Niamh, do you want to start? And Andrew can follow on.
A simple question with a complex answer, I think. So how do we get politicians to understand the complexity of the issues that the people that we work with and for is part of that kind of policy and narrative? Is that the question? I think that's a really great question. I actually think that what we need to be doing is stepping back and providing spaces for people who use drugs and people who are having issues to share those stories. I mean, it really, one of the things that we've talked a lot about the organisation, I think in this field, it's been really challenging to do that work, to bring that lived and living experience into the space, because also too, you don't want to be exploitative. This needs to be done in a really, done with the community in a really constructive way that doesn't cause harms. And so, you know, talking to lots of people who I've worked with in the field over the years, some of the things that we really want to do is this idea of, you know, adverse childhood experiences and talking about why, for many people, not all, but for many people, trauma is a driver. And I would take trauma out into not just individualized experiences of trauma, which are horrific, but also the greater kind of societal trauma that's caused by poverty, for example. But how we tell those stories by sort of reminding politicians that, you know, when these people were children, you wanted to protect them, like you cared. Or you at least pretended you cared. and now, in this arbitrary way, that when they move into adulthood and they start to use substance to deal with those traumas, you immediately start to criminalize them. So I think there's a piece of work that we want to do around that that's really interesting to me. But it's been a real feeling and a real challenge. And that's why I think we have to start to build movements that are calling across the piece for a type of decriminalization that really removes the state from people's drug use, unless they need support, and that's it. So I hope that helps.
Thank you.
Yeah, I mean, I think it's a very important issue. I touched on it briefly during my talk about the social determinants of health and poverty and inequality, and I think one of our jobs as academics is to illustrate that much more clearly. People often narrowly think poverty is just about income, but poverty is also about aspiration and hope as well. So you need to give people the opportunity for training, for employment, for housing, because all these things combine to give people the best chance of recovery in whatever form is important to them. So I think we're trying to work on that more, and I think there has been a contrition in some governments that they have ignored that side of things and focused too much narrowly on singular treatments.
If you're having difficulty getting out of your chairs to get a question, please use the app if you wish. Is that another question from the door? Is that someone waiting for a chair? No. Right, no, so, right, any other questions? Someone's doing the long brave walk, hopefully.
Al Story. Oh, sorry. Sorry about that. Al Story run Find and Treat, which is an outreach service in London. Brilliant intro, but I'm just going to raise a concern with this rather old concept of the social determinants of health, which we still keep dragging out. You know, the more we unpack this concept and the more we actually relate the content of your talks to the social determinants of health, it's quite clear that it's the political determinants of health to me. Yeah. And why don't we just call it what it is?
Yeah, I couldn't agree with you more, Al. I think this is something, and it's hard, isn't it? Because what we're talking about is trying to change society at its core. It's not just the folks that we work with and for. It is about changing society. It's about a better, fairer society. And for some politicians, it is really useful to demonize populations, certain populations. So I would say people who use drugs, particularly people who use drugs dependently, and then also people who are migrants. You know, you see constantly that othering that goes on, that the problems in your community are not about our policies, but about these people, and how we need to, again, bring light to that. So it's just constantly, I think, in those environments where we're working with politicians and policymakers, is trying to express that clearly and then start to talk about solutions. But it is a real challenge. Like, I think certainly over the last 2 years, you know, with COVID and, you know, with the racial justice uprisings, for example, I think we've reflected a lot about what are the solutions to this. And I'm slightly concerned that incremental change gives us a longer path to fundamental change. And so how do we start to work across different movements to really push for policies that will, you know, possibly eradicate poverty, you know, universal benefits? How do we make sure we have rent controls that are workable? All of those different things, and that we work with different, we work in solidarity with different movements. I actually think that's the only way we will get the kind of real change that we want to see.
And apologies for me, I'm public health trained, so social determinants of health was ingrained up there. Apologies. Thank you very much.
Any more questions? Going once. Going twice. Sold. Thank you very much. Thank you to the two speakers and for a good opening session. We're now moving on to the first of the abstract presentation sessions. So there have been 2 abstracts selected who are highly scoring to open this part of the session. And it's my pleasure to invite Dr. Jack Stone from the University of Bristol, who's getting support from his cheerleaders as he walks to the stage, who's going to talk to us about the impact of disruptions to services for people who inject drugs in Ukraine, modelling the potential impact of Russia's invasion.
Thanks, John. So I've got no conflicts of interest to declare. I'm going to begin by giving a brief background on injecting drug use in Ukraine and the interventions that are available for people who inject drugs. Then I'm going to present some modelling looking at the potential impact of disruptions to those interventions. And really, this is worst case scenario. What if these interventions had ceased operating for 1, 6 or 12 months following the invasion or start of the invasion? Then I'm going to present some data on how access to interventions has actually been affected since the invasion, and then some conclusions. So to start with, Ukraine has one of the highest per capita rates of injecting drug use in Europe, with around 350,000 people who inject drugs. This population has a high prevalence of HIV and hepatitis C in Ukraine, so 1 in 5 are infected with HIV, and 70% have been infected with hepatitis C. Opioid agonist therapy, or OAT, is available, but at very low coverage, around 5%. And HIV treatment, or ART, is available at moderate coverage, so just over 50% of those infected with HIV receive treatment. But both of these interventions had been scaling up prior to the invasion. So most funding for prevention, HIV prevention services in Ukraine, goes to non-governmental organizations, or NGOs. And these organizations distribute sterile needles and syringes, condoms. They link people to OAT. They They provide HIV testing and counselling, and also link those people diagnosed with HIV to treatment at government centres. And between a third and a half of people who inject drugs are in contact with NGOs. So we've actually been working with Alliance for Public Health in Ukraine for a couple of years, evaluating the effectiveness of these NGOs in Ukraine. And the first part of this was analyses of the 4 national IBBS surveys among people who inject drugs. By comparing those that are clients to those that are non-clients, we find that clients are much more likely to have used sterile needles at their last injection, to have used condoms at their last sex, and to be on OAT. And then amongst those that test HIV positive within the surveys, the clients are much more likely to be receiving HIV treatment. So that was work that was led by my colleague Adam Trickey and was published earlier this year. Then using these effects, I've done some modeling in Ukraine that shows that had these NGOs not been operating since 1997, HIV incidence would be double what it is today, and hepatitis C incidence would be a third higher. We also find that NGOs are highly cost-effective in Ukraine. So the war between Russia and Ukraine didn't start this year. It's been ongoing since 2014 with the annexation of Crimea. And what we know is that within 10 days of occupying Crimea, OAT was stopped. Roughly 800 patients receiving it in that region. Around 200 patients who relocated to mainland Ukraine were able to continue treatment. But over 16% of those who didn't receive care in other regions, they died within 3 months, and mostly from overdose or suicide. So I'm sure everybody knows that Russia launched its full-scale invasion in late February this year, and we wanted to use our existing model that had been used to evaluate NGOs to estimate both the short and long-term impact of disruptions to services for people who inject drugs following the invasion. So it's a mathematical model of HIV and hepatitis C transmission amongst people who inject drugs. It includes HIV transmission through injecting risk and heterosexual sexual contact, and then includes hepatitis C transmission risk through injecting. In terms of interventions, it includes OAT, which halves HIV and hepatitis C transmission risk, but also improves the HIV cascade of care and also treatment outcomes. The model includes HIV treatment, or ART, which reduces HIV transmission risk and mortality, and this is linked in the model to viral suppression, which we know that OAT increases. And then finally, we model NGOs, which increases engagement in OAT and HIV treatment, reduces injecting risk, and increases condom usage. And the model's parameterized and calibrated primarily using 4 rounds of national IBBS data with around 9,000 participants in each survey. So in terms of the model analyses, we wanted to estimate the potential impact of full disruptions to interventions. So what if NGOs, OAT, or ART services ceased from the beginning of March for 1, 6, or 12 months? And we compared this to a scenario where coverage of all interventions is unaffected. So we measure the impact in terms of additional number of HIV infections, additional number of hepatitis C infections, and additional number of deaths over 1 year and also 10 years. And then using the projections, we can actually estimate the impact per 100-person year of closure of each intervention or all combined. So these figures show the 1-year impact of closures to all interventions, so all 3 of those interventions that I've mentioned. On the left, we show the absolute impact, and on the right is the relative impact. So if you look at those small red boxes, this shows the impact of a 1-month closure to those 3 interventions. So this would result in just under 300 additional HIV infections over a 12-month span, an increase of 6%. 227 additional hepatitis C infections, or 1.5% increase, and 250 deaths, or a 0.7% increase. And this impact roughly scales linearly with the length of closure. So if you look at the blue bars, which show the impact of a full 12-month closure to these interventions, we see roughly over 2,500 additional HIV infections, hepatitis C infections, and deaths. But these short-term disruptions also have longer-term impact over not just 1 year. So now I've added on the right-hand side of this figure the impact over 10 years. So we can see that the impact across all three of our outcomes is higher over 10 years than it is 1. And this is particularly true for HIV infections where the impact is over doubled. So a 12-month closure would result in an additional 2,800 HIV infections, but over 10 years, it's 6,600. And when we look at the impact per 100 person years of each intervention missed, we see that it's HIV treatment that has the greatest impact on HIV infections and deaths. So that's the impact of full closures to these interventions, but how has access been affected in Ukraine? So if we start with OAT, this figure shows the number of patients on OAT in each month in 2022. And nationally, there's been an increase of 12% or 2,000 clients since February to August. But there was an initial reduction of around 5% in March. But we know that actually there's been very large reductions in the regions within the conflict zones in eastern Ukraine. And actually Luhansk, where there's been the worst of the fighting, OAT was stopped by Russian authorities when they took control. Many regions have actually shifted from providing supervised dosage to a 30-day supply of OAT within the conflict zones. And we know that during COVID, these changes improved retention, reduced mortality for patients, and actually allowed a scale up in treatment because providers could just see more patients. There has, however, been prioritization of medicines for patients at government clinics, particularly in these eastern regions. And this has led to some private clinics having to reduce dosages to suboptimal values. So whilst nationally the number of patients on OAT may have increased, the effectiveness of treatment has likely reduced for certainly this subpopulation. In terms of HIV treatment, this figure shows the national number of people who inject drugs on ART each month for 2022. And nationally, this number has been fairly stable. It's increased by 1% from January to August. But this had been increasing prior to the invasion. Overall, so not just among people who inject drugs, we know that HIV diagnoses and initiations onto treatment have been reduced by 26% this year compared to previous years. And then when we think about the conflict areas and the rest of Ukraine, we know that a third of people receiving HIV treatment reside in the areas affected by conflict. And within these regions, access to treatment remains challenging. Only 9% of HIV treatment sites are operational in Luhansk, for example. So if we look at how the number of people accessing HIV treatment has changed over time, the blue line here shows the regions in eastern Ukraine within the conflict zones, and the yellow line shows the rest of Ukraine. So within the conflict zones, the number of people accessing treatment has reduced by 9%, but the number has increased by 3% in the rest of Ukraine. As for NGOs, so this figure shows the change in the number of people who inject drugs accessing NGOs compared to the average across previous 2 years. And the reason that this data is shown is one, we actually had the data for NGOs and we couldn't get it for the other two interventions, but also coverage typically increases across the calendar year, and so it's important to compare January this year to January in previous years, and same for other months. And in the rest of Ukraine, we can see that the number accessing NGOs has increased mostly compared to previous years, but in the regions in eastern Ukraine within the conflict zones, since March, there's been dramatic reductions. And then particularly in April, where there's just under 40,000 fewer people accessing NGOs, that's a 3/4 reduction in April. And then within 2 regions within this conflict zones, no clients at all have been able to access services since March in Luhansk and Crimea since April. And when we put these 2 lines together, we actually see that the number accessing NGOs nationally has been lower since April. So our modeling showed that short-term closures could have substantial impact, particularly on HIV infections, both in the short and long term. But the available data suggests that these scenarios were likely pessimistic. There hasn't been national reductions for OAT and ART. the numbers have actually increased since January. However, these had been increasing before the invasion, and so it's important to consider whether these increases could have been more. What we do know is that the number did increase outside the conflict areas, but did reduce in the regions with conflict. Since April, the number of clients nationally accessing NGOs has been reduced compared to previous years. And this is driven by large reductions within the regions within the conflict zones, particularly in April, where there was this 3/4 reduction. So what we can do is calculate the number of person years that may have been missed for NGOs, comparing that with previous years. And we estimate that around 5,000 person years of NGO contact has been missed. So using this with our estimates of the per person year impact, we can estimate that these reductions will result in 116 additional HIV infections, 126 additional Hep C infections, and 35 additional deaths over the next 10 years. The war is having wider effects than just disruptions to services. One of these is there's been a reduced supply of drugs in Ukraine, roughly doubling the cost of drugs. But interviews that the Alliance for Public Health have done suggest that there's actually been little reduction in injecting frequency. Instead, people have been changing the drugs that they use. Another concern is that most people who inject drugs acquire syringes from pharmacies. They purchase syringes from pharmacies, particularly those not in contact with NGOs. And so pharmacy closures, limited availability of syringes in pharmacies, and indeed deteriorating finances of people to purchase syringes may increase injecting risk, particularly among those not in contact with NGOs. And finally, in Russia, funding has been prevented from reaching NGOs providing harm reduction from international donors. And so it's actually possible that the war is having greater impact on services for people who inject drugs in Russia than it is in Ukraine. Finally, I'd just like to acknowledge all of my collaborators and co-authors on this work, but particularly those from the Alliance for Public Health in Ukraine, who are long-standing collaborators. Thank you.
The paper is now open for questions, either online or by the app or in person, if anyone would like to make their way to the microphones. I'm struck by the fact that you're able to produce data from Ukraine this year about the amount of drug being prescribed for HIV, for hepatitis C, and for OAT. I suspect Scotland couldn't give me that data, not this year, and perhaps not next year. Andrew would get upset, but that's extraordinary.
So on that point, I'd just like to say that is really due to the Alliance for Public Health. They were in contact with the Centre for Public Health to get the ART data, and they were working up until Saturday to provide some of the data that I've just presented. So really due to their hard work.
Extraordinary. Any questions? Oh, sorry, microphone 4.
Hi, thank you. I just have 2 quick questions. I wonder if you could quickly speak about your counterfactual in your modeling, and also did your analysis assume a population size stability, or did you account for any kind of migration?
Yeah. So the counterfactual, so the 2 scenarios that we were comparing, so the one is complete closures of all interventions or each individual in turn. And we were comparing that with a scenario where interventions remain stable from 2021 onwards, I think. And then the second, no, we didn't try and build into sort of deaths through as a consequence of the war to affect the population size. So the population size has been reducing over time, and we allowed it to carry on reducing, but not any additional reductions.
Thank you.
Thank you very much, Jack.
Thank you, Jack. It gives me pleasure now to introduce Dr. Marion Selfridge. The second paper, The Implications of Using Current Mechanisms of Opioid Agonists. And Marion is a research manager focusing on HIV and Hep C in Kool-Aid Community Health Centre alongside postdoctoral research and Canadian Institute of Substance Use Research. Over to you, Marion.
Thank you so much. Sorry, I'm just making sure this works. And I'm just so excited to be here today. And I'm so excited about all of the presentations that have already happened that really lead into the discussion that I'm going to have with you. I'd also say that I put this in as a late breaker and imagine myself in a room of like 15 people. And suddenly here I am, hey? So just, can you all give me just a big breath of like, it's going to be okay. Thank you. This is work done at the Canadian Institute of Substance Use Research, where I am a postdoc. Here are my disclosures. This research took place on the traditional unceded and continually occupied lands of the 198 First Nations in what is now known as British Columbia. So I'd really like to acknowledge the disproportionate impact of the toxic drug supply on First Nations, Indigenous, and Métis peoples as a result of historical and ongoing impact of colonization. In this work, we continually remember and honor team members, family, and friends that we've lost to the toxic drug supply that has claimed over 10,000 people in British Columbia since 2016. So this presentation offers some insight into the implementation of safer supply, what we've been talking about in all of these presentations this morning already. So one definition by Kapud describes safer supply as a legal and regulated supply of drugs with mind-body altering properties that traditionally have been accessible only through the illicit market. So I can only scratch the surface today. Join us tomorrow at 3:45 for a panel of prescribers, researchers, and drug user activists to discuss different versions of what this might look like. So far, almost all research around safer supply has been a prescribed alternative rather than other versions of a legal and regulated supply. So in supervised heroin-assisted therapies, comparisons of heroin versus hydromorphone, supervised injections, and these more current tablet hydromorphone prescribing programs, various benefits have been noted, including improvements in health and mental health, reduced use of drug use, and involvement with the police. What was mentioned already is this idea that COVID-19 has provided some possibilities. So in British Columbia, COVID-19 brought these other opportunities to look at models of safer supply, including what was called the Risk Mitigation Guidance, or RMG, released in March 2020. So the RMG provided support for the prescribing of opioids, stimulants, and benzodiazepines, as well as medication alternatives to alcohol and nicotine use for persons who are at risk, suspected, or positive for COVID-19, combined with high likelihood of withdrawal, overdose, or other drug-related and systemic harms. So the research that I'm sharing today is part of a mixed methods provincial evaluation of RMG. We drew on multiple data sources, including administrative health data, surveys with people who use drugs, and interviews with some of those same people, as well as service providers and health planners. I'm imagining a tsunami of papers that will be coming out in the next little while. We're almost there, and you'll see some things already released. This study particularly relies on collaboration with people with lived or living experience of drug use. Amazing peer research associates have been involved throughout the process in designing data collection tools, recruitment analysis, and knowledge translation, as well as all kinds of advocacy. Today, I'm specifically talking about the findings from the 55 qualitative interviews that I conducted with people who had received or were trying to receive a prescription for RMG, a very diverse group of people who use drugs across the province. So I'm going to just dive right in to some of the findings around the barriers and facilitators to implementation. Many people spoke about not knowing about RMG or how to access it. Most frequently, they'd heard about RMG through word of mouth, drug user groups, outreach teams who help them get connected to prescribers. Folks in urban centers like the downtown east side of Vancouver or Victoria, where I live, had much easier access than in smaller or more remote communities. Participants, as the one shown here from a smaller community, described the challenges of finding a doctor and the issues of prescribing narcotics. She said, the only problem with it, though, it's only OAT providers providing this sort of care. It's able to be done by GPs, as far as I understand. Basically, we have a shortage of doctors. 1 in 4 are unconnected to a GP, and the rest are walk-in clinics, are not able to prescribe opiate-based or narcotic-based drugs, so we're quite limited. So it makes sense that OAT providers that have the knowledge and expertise and the infrastructure to provide prescribed RMG, that they would be the folks that would take this up. However, it's also these prescribers that are the same ones that experience the stigma related to drug use that impacts both people who use drugs and those that work in the systems that work with them. Here, someone said, I know doctors involved in safer supply are hated and disliked and other stuff because they are the same people that ran the methadone thing before and stuff. There's probably not a lot of doctors jumping up and down to volunteer for this. The overall opinion and stereotype and everything of the people looking for safe supply, the junkie thing, the methadone people. This notion of doctors being scared also flags the history of the backlash to what was seen as overprescribing of opiates that led to a strong shift in the 2017 Canadian guidance around opioid prescribing. This changed from recommending active, generous use to restrained, sparse, and last resort use of the treatment for chronic pain. So participants also spoke about a disconnect from what they understood RMG to be, this providing of a safer supply of drugs, versus this notion of feeding into addicted behavior, which continues to blame people for their drug use. And like just even the doctor, you could just tell he's there to like sign a script and get as many people through, and like didn't care really. He says stuff to you like, oh yeah, that's what you all say. Many shared past and current negative experiences with clinicians as they tried to access healthcare services that left them feeling angry, demoralized. I think the stigma, like I'm really caught up on some of the things my doctor said to me. It's really demoralizing and dehumanizing when we're experiencing these things from healthcare workers, and they're the ones that should be treating us with dignity, respect, and compassion. However, a number of participants talked about the positive relationships that they had with prescribers and other support staff. Many people had hopes for RMG that was about having more control around the drugs that they used. I want to try to see if I can wean myself off fentanyl, and so far the Dilaudid just isn't touching it. As the Cadian dose goes up, the OAT, it becomes more manageable to do what I want to do with the Dilaudid. It's because the Cadian works so well that I'm willing to even try this again. I've been actually really impressed with it. It doesn't work as a total substitute, but it's allowed me to decrease my intake quite drastically. So for others, they were clear that they didn't want an OAT at all, but weren't able to access RMG without trying them. My substance of choice is Dilaudid. However, a lot of physicians weren't comfortable prescribing a quick-acting opioid without a long-acting opioid. I knew from the beginning that I only wanted Dilaudid, tried to self-advocate, but of course the doctors had to go through the steps necessary. I had bad reactions to both the Suboxone and Cadian, borderline seizures, more like an intoxicating effect. Most people described accessing RMG within an OAT model of care, or what Gomart calls a network of practices, including daily dispensing, limited carries, and urine drug screens. The vast majority of people were prescribed RMG daily, especially when connected to a daily witnessed OAT. In some communities, RMG was actually delivered to them, while few people liked the routine that was part of the daily while a few people actually liked the routine that was part of a daily connection to staff, most people saw it as basically a handcuff to the pharmacy, right? Like you have to be somewhere accountable. Doctors don't want you to miss more than 2 days, they cut you off. Providing urine drug screens used within the ONT model, prescribing was required for many participants accessing RMG. I think UDS is degrading. So if I want to do street drugs, like if I want to do cocaine and party, I should have that option doing it. I'm 41 years old. I'm not a fucking kid. I find it degrading. These are similar critiques from what we've seen in research around OAT. We saw a lot of the positives in the earlier presentation, but there are a number of factors that lead to retention rates as low as half to 1/3 over a year. So I asked participants about the changes that they experienced and they've been accessing RMG prescriptions. Most participants said they had experienced a decrease in overdoses or no change. we talked about the impact of RMG on withdrawal and craving. Some of the extreme symptoms of feeling like puking my guts out, feeling like I wanted to die or shitting my pants were reduced. We love that quote. Consistently, participants told us that dilaudid tablets were not strong enough, and it doesn't do the trick. And they were left white knuckling between doses. So while some people had decreased their illicit drug use, with a few completely stopping using drugs from the toxic supply, most continued to supplement their RMG with illicit drugs. Consistently, participants described how the amounts of RMG they were prescribed were not strong enough. You can't expect hydromorphone or morphine to even stand a chance against fentanyl. Now we basically have to fight fire with fire. I'm addicted to fentanyl, not morphine, not Dilaudid, not whatever else they're prescribing to other people. A lot of the drugs around here have benzos in them, right? However, there were several other positive impacts. Having an RMG prescription meant people did not have to hustle as much. Others described having more time to get things done, taking care of themselves, looking for housing as well as mental health, as well as attending mental wellness. Some engaged in less criminal activity. And RMG was also empowering. Here this participant describes buying food with half the money she normally would have spent on illicit supply. And when I came home carrying some snacks and stuff, I felt so good. I get to put this little bit of food that I have in my fridge and in my cupboards, and it felt empowering. People described improved health, reported change such as reduced pain, infections, lung issues, and eating regularly, as well as less anxiety. Participants had many recommendations for improving the RMG program. I've highlighted a few here. Fundamentally, listening to people with lived and living experience in all aspects of prescribing and program development is the only way to make the changes necessary to reduce the stigma around drug use and the loss of thousands of deaths from the toxic drug supply. Participants have suggested having a greater range of opioid options, including both heroin and fentanyl in both smokable and injectable formats. Stimulant users particularly wanted more options that better replace their current stimulants and the ability to smoke their substances. Participants recognized that prescribers needed adequate training and support, where community champions of RMG are identified and supported to reduce barriers. The doctors need more authority to prescribe stronger narcotics. RMG is not what I need and it's not what I want, but it's what we'll have to do for now. It's not smokable, not strong enough. It's not relaxation promised like the fentanyl or the heroin. It's frustrating. It's like we're thankful and grateful that the government is doing something, but at the same time we're frustrated that it's just not enough anyway. Within a prescribing model, people wanted more options for longer prescriptions and less scrutiny, moving away from OAT-style surveillance of daily witnessing and UDS to be trusted to know what is best for them. People want to work with their doctors in a collaborative process where their goals help guide the process. I'm sure prescribing physicians, they probably already are making every effort they can, but to make it as consultative a process as possible with your client, or else it's not going to work, you know? Like your goals of trying to help someone, it's not going to work. Participants had suggestions for alternative low-barrier models to ensuring that people who use drugs have access to safer supply within and outside the healthcare system. Compassion clubs run by persons with lived experience would enable folks to have access to a non-toxic supply with more decision-making control from themselves, enabling a broader reach for those not interested in accessing medical care at this time. Finally, legislative change that decriminalizes drug use was strongly endorsed by participants as the only way forward to reduce medicalization, criminalization, and stigma around drug use. So, a few conclusions. Current policies and structures for OAT provision were used in this RMG implementation. The legacies of previous changes and histories have had both an impact in the experience of RMG implementation, and the shifts in guidance for GPs and changes in formulations of OAT continue to impact trust. And while participants saw RMG as a step in the right direction, dosing was too low to stop withdrawal and not in a format to adequately replace current fentanyl or stimulant use. And while OIT does provide positive impacts for some people accessing RMG, the structural vulnerabilities that have been demonstrated through critiques of OIT are also the same ones present in RMG implementation. Various models of safer supply are needed to tackle toxic illicit supply. So this is just scratch the surface of this issue. Let's continue the discussion. I'll be sharing a little bit more this afternoon in a presentation about the clinic that I work at and the first 500 folks that accessed RMG through the clinic. And again, please join us tomorrow at 3:45. Here's a few wonderful websites to check out, including the Canadian National Safer Supply Community of Practice. There's folks in the house tonight today that are part of the organization, and there's a wealth of resources there, as well as CoLab, which is part of the organization that I work for. Many thanks to everyone who's here today, especially the team members that have been involved with the project. And I'm thinking especially of Phoenix, Beck McGreevy, who is part of the Drug User Liberation Front, who wrote a very similar paper that's out there that if you'd like more information, I'm happy to share as well. Thank you.
Thank you, Marion. And we have probably 1 minute or a couple of minutes just to ask one question, if anyone's got a question. No? But they can, but you can be found later on today. What time?
Is it 2?
Yeah, 2 something. Okay. Well, so
that's a bit unfair for a jet lagged Canadian.
Sorry.
I have
one question.
Yeah,
perfect.
I have a quick question. Tessa Windelings from Belgium, Antwerp. It's lovely to see that you have alternative ways to work with people who use opiates, but I was wondering, did you also do research on the prescription of stimulants?
On the prescription stimulants?
Yeah.
Yes, we asked lots of questions for folks who were prescribed stimulants, and just there wasn't time enough to talk about it today.
Okay.
Yes, but absolutely a wide variety of people. Usually about a third of the folks that we talked to in the surveys had been prescribed stimulants as well, usually Ritalin, methylphenidate, as well as a few others.
But not cocaine, amphetamine, because these are the people who are really hard to reach in normal services.
Yeah, I think I know that we were able to connect with lots of drug user organizations that were fundamentally asked for this research and evaluation to happen, and so they provided lots of opportunities for folks in a variety of settings to come forward to be able to be involved with both the survey and the qualitative interviews.
Okay, thank you.
Thank you very much.
Thank you.
So just a few quick housekeeping points. All the catering will be served in the exhibition halls, which is out and left, and you should find it. You can take a look at the posters, say hello to our exhibitors. We also have a cinema in there, which is showing films on models of care for hepatitis C and drug treatment options from around the world, presented by Connor Ashley. You just come in, pick up a set of headphones, and they'll be on continuous loop throughout. But of course, you should be here for the major exciting sessions as well. And then there are the poster tours this afternoon at 3:40. Again, headsets, just grab them from the INHSU cinema. Enjoy your coffee. I look forward to seeing you all back later.
And don't forget to download the app if you haven't done it already. Thank you. Thank you, John.